শুভ সন্ধ্যা। সবাই কেমন আছেন? বরাবরের মতো প্রতি রবিবারই আমাদের একটা উদ্দেশ্য থাকে যে ফিজিও নিউজ 24 এর পক্ষ থেকে আপনাদের জন্য, বিশেষ করে ফিজিওথেরাপি চিকিৎসকদের জন্য একটি ফ্রি ওয়েবিনার উপস্থাপন করা। এবং প্রতি সপ্তাহে আমরা চেষ্টা করছি অথবা মাঝে মাঝে কিছু ব্যক্তিগত জটিলতা বলেন বা বিভিন্ন কাজের চাপে হয়তো আমরা করতে পারছি না। তো এই সপ্তাহে আমরা প্রোগ্রাম করছি। তার মধ্যে গত শুক্রবারে আমরা ইন্ডিয়া থেকে একজন প্রফেসর স্যার এসেছিলেন আমাদের সাথে, তার নলেজ শেয়ারের জন্য। এবং আজকেও আমরা খুবই আনন্দিত, আমাদের সাথে আরেকজন বিদ্যান মানুষ আমাদের সাথে উপস্থিত হয়েছেন এবং ওনার নামের সাথেও আসলে যায় ওনার যোগ্যতা, কারণ ওনার নাম হচ্ছে ডক্টর দেবেন্দুনারায়ণ বিদ। তো স্যার ইন্ডিয়াতে বেশ নাম করা, বর্তমানে উনি অনেকগুলো শিক্ষার ওয়ার্কশপ ফিজিওথেরাপি, বিশেষ করে ম্যানুয়াল থেরাপিতে আয়োজন করেছেন। এবং দীর্ঘ লকডাউনে আসলে সবকিছু যেখানে বন্ধ সেখানে স্যার অলরেডি আমাদের নলেজ শেয়ারে কাজটা শুরু করেছেন এবং আশা করি সামনে আরো সুন্দরভাবে আসবে। এবং আমরা খুবই আনন্দিত যে এই স্যারের মতো জনেরা যারা আসলে সবসময় ব্যস্ত থাকেন, তারপরও আমাদের আসলে আমরা গর্বিত যে আমাদের এই ছোট একটি পরিসরে তারা সময় দিচ্ছেন এবং আমরা আনন্দিত যে আমাদের জ্ঞানকে উচ্চতর স্থানে পৌঁছানোর জন্য তারা সহযোগিতা করছেন। এবং ভবিষ্যতে আমরা চাইবো যে স্যারদের কাছ থেকে আসলে সরাসরি জ্ঞানগুলো যদি হাতে কলমে পাওয়া যায়। তো আসলে কথা বাড়াতে চাচ্ছি না, আমাদের সাথে অনেক বিভিন্ন দেশের পার্টিসিপেন্টরা যোগদান করেন। তো সেই কারণেই আসলে আমরা সরাসরি চলে যাবো ইংরেজিতে। তো ধন্যবাদ সবাইকে এবং সবাইকে আমন্ত্রণ জানাচ্ছি আমাদের প্রোগ্রামে। So thank you everybody and welcome you all. Good evening. Like as before, we are organized this such type of webinar for the engagement of our physiotherapy profession, and that's why this time we have done this type of webinar on behalf of our PGDSPT. And this time we have one of the professor from India, and he is a famous physiotherapist, and he is one of the founder of Physiotherapy Institute that is called Manual Therapy Academy, Surat, India. He is known like Dr. Dibyendunarayan Bid, sir. And he has completed his MPT and postgraduate diploma in sports and also Ph.D. So he is the senior lecturer of Sarvajanik College of Physiotherapy, Surat, India, and also he has a 24 years teaching and clinical experience. So today he is going to share a valuable knowledge with us on the lumbar spine manual therapy assessment. So I will not give his valuable time. I will directly invite him to, sir, please join with us and give you such a valuable lecture. Thank you, sir. Sir, you can start now, sir. Sir, can you hear me, sir?
Yes. Shall we start?
Yes, sir. It's time for you, sir.
Okay.
Sir, am I audible, sir? Sir, am I audible, sir?
Yes, you are audible.
Okay, sir. Now, time is yours, sir.
Okay. We are going to give introduction now.
Sir, already I have given your introduction, so you can just start yourself, sir.
Okay, I have to start now, right? Ladies and gentlemen, very good evening. Today I will discuss manual therapy assessment of the lumbar spine. Okay. I am Dr. Dibyendunarayan Bid from Sarvajanik College of Physiotherapy, Surat, India. Let us talk about little bit of prevalence of low back pain. As all of you know that low back pain is a major health burden in the world. 60 to 80% of the people, they suffer from low back pain anytime during their life. And we see that low back pain is generally self-limiting, but it may progress to a disability in 5% of the patients. Up to 90% of patients recover in 3 to 4 months, 70% recover in 1 month, and 50% in 2 weeks without any formal treatment. Then what happens? Only the 5% of the remaining 10% will not respond to conservative care of physical therapy or care from any other rehab professionals. So 5% people will be going to become chronic cases. They become disabled. Here you see little bit of anatomy. You are familiar with the structure of lumbar spine. It is the most load bearing joint in our human body. Here I will talk little bit about the motion segment. Two vertebral bodies and intervening intervertebral disc and its end plates. Together they make the motion segment. This motion segment is responsible for movement in the lumbar spine. The disc is thick in the lumbar area, and this motion segment is responsible for movement in the lumbar spine. In the lumbar spine, all the movements are guided by the intervertebral disc. And because of the presence of the disc and vertebral bodies, the lumbar spine gets a natural lordosis. The shape of the vertebral body and shape of the disc provides the natural lordosis in the lumbar spine. And the orientation of the facet joints limits the lumbar rotation. And these facet joints, they help in stability during rotation in the lumbar spine. In the lumbar spine, there are many muscles which provide dynamic stability, and there are many other muscles which provide static stability. That means they are stabilizers. Little bit I will mention about biomechanical part. In that we will touch the coupled motion. So what is coupled motion? Coupled motion is the rotation or translation of a vertebral body about or long or along one axis that is consistently associated with the main rotation or translation about another axis. So let me simplify it. When there is motion in along one axis, always there is motion in another axis. So simultaneously motion will be taking place in two axes in coupled motion. But in case of lumbar spine, predominantly the motion takes place in sagittal plane. A rotation is minimal. So coupled motion is also very minimal in lumbar spine in comparison with cervical spine. So basically coupled motion is negligible in lumbar spine. So in manual therapy techniques, they do not talk about coupled motion in lumbar spine. So most of the motion occurs in sagittal plane, then it is followed by coronal plane and very minimal in transverse plane. Now, little bit we'll talk about assessment and diagnosis. McCarthy and others, they have outlined three categories of low back pain diagnosis. In one category, they have put nerve root related problems. In second category, the low back pain which is because of serious pathology. And third category, they have kept non-specific low back pain where there is no specific cause. That's why it is called non-specific low back pain. Now, under the heading of nerve root assessment, there are three types of referred pain which originates from the lumbar spine. One type of pain may be because of myelopathy, because of the compression of the spinal cord. Second one is because of nerve root compression, radiculopathy. And third type is somatic referred pain. That is, other than myelopathy and radiculopathy is termed as somatic referred pain. It may be coming from the ligaments, it may be coming from the bone, it may be coming from vascular structures, or it may be from muscles. Now, we have to assess red flags, red flag assessment. What is it? This is danger sign. There may be some sinister disorders which can be termed as red flag. And if these are present, that will cause chronicity of low back pain. So 5% of the cases of low back pain may be having red flag, and we have to identify those red flags. So there are three major types of red flags. One is non-mechanical spine disorders, second one visceral disease, and in the third type there are some miscellaneous conditions are there that we see in a table. Please pay attention to this table which indicates some serious conditions regarding low back pain disease. So non-mechanical spinal disorders, which is approximately 1%, it includes neoplasia, means cancer, it could be infection, some seronegative spondyloarthritis like ankylosing spondylitis, psoriatic arthritis, reactive arthritis, Ritter syndrome, inflammatory bowel disease. These are the things which comes under non-mechanical spinal disorders, and their percentage is approximately 1%, slightly more or slightly less. Second type is again 1 to 2%, which is visceral disease. That also classified into 4 types: pelvic type, renal type, aortic aneurysm, and gastrointestinal. So under pelvic type, prostatitis, endometriosis, pelvic inflammatory disease. This also may lead to low back pain. Renal conditions like nephrolithiasis, pyelonephritis, renal papillary necrosis, and aortic aneurysm is the same. And gastrointestinal conditions like pancreatitis, cholecystitis, peptic ulcer disease may cause low back pain. And some miscellaneous conditions like Paget's disease, parathyroid disease, and certain hemoglobinopathies may cause low back pain. Now we'll see the diagnostic classification of low back pain. Here one model is given. Under that we can divide them into 3 types of index strategies. The first index is status index, second one prognostic index, and third one is patient response model. Now we'll see each one by one. So So what is this status index model? This model involves the use of physical impairment classification, and it is designed to discriminate among faulty pathological tissues, where you can define there are certain faulty structures. Based on that, we tell the status. And this can be further subdivided into homogeneous categories based on suspected pain generators. Whichever structure is involved, we can tell that this is the pain generator in the low back pain. Second category is prognostic index model. Here we use certain questionnaires like pain related fear, coping behavior, and these things are used to predict the pain progression. So if you are using pain related fear or coping behavior, in the outcome measure, if the score is high, that means they will have potentially poor progression. So these questionnaires are developed, or they are based on data, pre-existing data, means we have already collected the data and we are modeling them for future prediction. So prognostic index models are retrospective in nature, and they suggest what will be the outcome in future depending upon the data. We have already developed the questionnaire, and questionnaire outcome will tell what will be the future prospect of the patient. Recovery will be good or poor, or it is not going to recover. Third one is patient response model. This model was given by Robin McKenzie and is one of the favorite model of the physiotherapist. So we collect data before the treatment, during the treatment, and after the treatment. And it is based on the response to movements during an examination. What we are looking for? Patient's response to movement during an examination. So here we look for pain provocation or reduction. By doing certain movements, pain can be increased, and by doing certain other movements, pain can be decreased. And this provides us some diagnostic assessment. So this model assesses provocation, reproduction, or reduction of pain response. And this response can be obtained by a single movement or repeated movement, or by positioning the patient in different positions, or by checking the abnormality of the movement. So in this assessment, we look for direction and form of the movement, and we find out the direction of preference, in which direction patient wants to move, and that is used in the therapy purpose. Despite having all types of clinical and diagnostic tests, we are still not sure what exactly is the impairment in the low back. We just speculate this may be the problem. And in most of the cases, we implicate that intervertebral disc is the primary pain generator. And other physical factors are of little predictive evidence in pain recovery. So as a physiotherapist, most of us think that only disc is responsible, but there are other structures which may also be responsible. So this patient response based model, it gives us clinician friendly classification model, and it does not have any validity challenges. Now we see that all of these three systems, index model and second one and this third one, response model, all these are not perfect. So you have to use them in combination. You have to adapt as per your requirement. Now we come to the actual part, that is clinical examination. So in the clinical examination, first we go through the observation of the patient. In the observation, we see postural syndromes. All of us are familiar with postural syndromes. In response to low back pain, person adopts some postures of easing the pain. Like you can see the lateral shift, that is one postural syndrome. So patient will prefer one particular position or particular posture that helps to keep the pain minimum. Second one is willingness to move. Patient's willingness to move should be observed by the therapist. It helps us to decide whether out of fear patient is not moving or he is having the actual range of motion. That you can differentiate. And also patient may be having some catastrophizing behavior. That also leads to reduced willingness to move. Now you can see postural changes associated with some structural dysfunction. If disc is herniated, it will lead to flattened back. Back will become flat. If there is presence of radiographic instability, it leads to excessive lordosis in the lumbar spine. And again, if there is sacroiliac dysfunction, again you can see flat back. And in case of degenerative disc disease, you can see hypertrophic supraspinous ligament. That supraspinous ligament will become hypertrophic, it will be palpable. If there is spinal stenosis, again it will lead to flattened back. And if there is facet impingement, person will prefer flexed back. On unilateral side, he will flex to one side. And if there is nerve root adhesion, it will lead to poor posture and patient will avoid forward flexion. He won't bend forward. So that indicates nerve root adhesion. So these are the simple observations which you can make out and connect with the structure. Now you see in this picture, patient is with a right lateral shift. So this shift can be determined by analyzing the position of trunk over the pelvis. You see, first you see the pelvis, then see the trunk. What is their relationship? So in this picture, the patient's trunk is shifted right over the pelvis. It's shifted to the right side. So generally, patient will exhibit a lateral shift toward or away from his or her pain side of pain or report of pain. So suppose if shift is toward the pain, this is described as ipsilateral shift. And when there is ipsilateral shift, it is because of central disc herniation. And shift is away from the pain side, then it is described as contralateral shift. And that is because of posterolateral disc herniation. So majority of the cases will be away from the side of pain. So majority of the cases will be posterolateral disc herniation. Now we'll see subjective history. In that you can see the area of symptoms, where is the pain, where pain is radiating. If you leave aside myelopathy, other two types of referred pain which arise from the lumbar spine, you can clearly make out. One is somatic referred pain. So this somatic referred pain is caused by noxious stimulation of structures or tissues intrinsic to the lumbar spine. That means other than nerve root and other than the spinal cord. So whichever pain is coming, that can be termed as somatic referred pain. And second one, radicular pain, it is caused by nerve root irritations of lumbar origin or sacral nerve roots. So when these roots are passing through the lumbar vertebral canal or through the foramina, at these 2 points it may get irritated and it will cause referred pain. Additionally, somatic referred pain, it may be because of secondary region of convergence. There are nerve roots which not only supply to the muscles, it also has supply to the visceral organs. If there is disease of visceral organs, that may send signal to the nerve root and it will cause musculoskeletal pain. So that phenomena is called convergence. So that can be termed as somatic referred pain. So this somatic referred pain is described as deeply perceived, diffuse and hard to localize. So mostly causes may be ligaments surrounding musculature, facet joints, IV disc or intervertebral disc. These things refer the pain to the lower extremities. Now we talk little bit about functional skills. You know, in our lumbar spine low back pain research, we talk about disability, pain and quality of life. But between these 3 items, disability, pain and quality of life, the relationship is poor. It is questionable. So concept of pain, psychosocial factors, biomechanical covariates, these all correlate poorly and it cannot exactly determine what is the extent of disability. It is difficult to say just by using functional skills. Mostly for our purpose, we use 2 instruments. One is Roland Morris Disability Questionnaire, RMQ, and second one, Oswestry Disability Index, ODI. And beside that, we have Tampa scale of kinesiophobia to measure the fear factor, and also we have FABQ, Fear Avoidance Belief Questionnaire. So using these questionnaires, the assessment is subjective. So what should be done? We should look for the concordant sign during each examination. So what is concordant sign? Concordant sign is when you do certain movement and at particular point pain comes. That is the concordant sign, and you can relate with some diagnostic level. Then you can say this is concordant sign. So in assessment, you should have a measurable baseline that you can compare with before, during and after each intervention and after applying each treatment technique. Means you have to have a baseline measurement that will be again repeated before the treatment, during the treatment and after the treatment. And that comparison will tell that you are moving in the right direction of the treatment or not. So in this context, the ODI and RMQ, they provide help in data gathering and measuring the treatment progression. Now we'll come to our actual point, active physiological movements. So first we'll talk about centralization phenomena. Centralization phenomena, it was proposed by the Robin McKenzie. He said that by doing certain movements, if area of pain reduces, then it is called centralization. And by doing some other movement, if area of pain increases, then it is called peripheralization. Now we'll talk about available range of motion. So in the lumbar spine, what range is available? Either in normal person or person with low back. It does not correlate well. A normal person may be lacking range of motion in the lumbar spine. And another person who is having chronic low back pain, he is also lacking range of motion. So looking at the total available range of motion is a fallacy. So that does not give you the idea of normality. So what you have to look for? We have to look for the segmental motion in the each motion segment of lumbar spine. Then comes use of repeated movements. By using repeated movements, you can find out discogenic pain symptoms. By using repeated movements, you can also find out the irritability of the conditions. Suppose at 1 repetition pain comes, or after doing 10 repetition pain comes. This will give you the differential idea that how much irritable this condition is. Also, in one direction pain will be there, in another direction pain won't be there. So that will tell you about the directional preference of the patient. Then fourth point, the use of sustained movements or postures. These sustained movements or postures are essential to detect the pain behavior of the patient. Patient may exhibit preferences in direction of sustained holds, or it may demonstrate reduction of pain once a segment is stretched or tension is released. In short, certain sustained movements will be well tolerated by the patient, and some other sustained movement may not be well tolerated by the patient. Here is the actual assessment, active physiological flexion. Now we have reached to the actual point that you have to assess. Now we have to see active physiological flexion, and in this we'll try to find out the concordant sign and determine the effect of repeated or sustained movements, and whether this response centralizes the patient's concordant sign. So once again I am repeating, what is concordant sign? At what point pain comes back. That is the concordant sign. Right? So you see in the first picture, patient is bending forward and trying to touch the toes. So it is flexion of lumbar spine. This goes through the 7 steps. So in the first step, patient is starting from the neutral standing position. And in neutral standing position, we take pain and radicular referred symptoms. Means we'll note down the baseline data. What is your pain in standing position? Is there any referred pain or radicular pain? That will be noted. In the step 2, patient will be instructed to flex forward to the first point of pain. Gradually, patient will flex forward, bend forward, and where pain is appearing, that point will be noted. And again, patient will be questioned about where is your pain, at what point pain came, and that will be termed as concordant. Means on doing certain movement, pain is appearing. That is concordant. Then in the third step, patient is instructed to progress past the first point of pain. And again, you evaluate symptoms. In the third step, you tell the patient, you go beyond the point of pain. And you are noting down the pain and symptoms. Then comes step 4. At this point, you will ask the patient to perform repeated movement past and or near the end range of the motion. So, patient will go forward and come back beyond the point of pain and up to the point of pain. So, he will perform repeated movements and will check the pain and symptoms. What happens? By doing these repeated movements, therapist has to see whether the symptoms are worsening or improving, or it is staying the same. That means either the condition will centralize, or it will peripheralize, or nothing will change. Then we go to step 5. In this step, we will check after doing repeated movement whether the range of motion has increased or decreased. By doing repeated movement, we are checking the range has increased or decreased. Now we come to the 6th step. If end range flexion was pain free, then you take up the slack. You see the picture, second one, and apply firm pressure on the back and engage the end field. So, therapist is applying firm pressure over the back, upper back, and pushing the patient towards the end field. And in the 7th step, at the end field position, if it is pain free, apply small repeated oscillations to rule out this motion. Means there is no dysfunction, you have to apply oscillation. If it is pain free, you say yes, there is no problem in the end range. If pain comes, then don't give oscillation in the end range after seeing the end field. So you see that here just a simple process of checking active physiological flexion. You can find out exactly where pain is coming. By doing repeated movement, pain is increasing or decreasing, range is increasing or decreasing. You are going to the end range, giving oscillation, and you are finding out whether you can engage the joint, lumbar spine in the end range or not. So this is about active physiological flexion. You get these many informations which goes through the 7 steps of checking the active physiological flexion. Similarly, we can perform active extension repeated movements. So here the purpose of this is to examine effect of movements on the patient's concordant side, like we did in the flexion. Same thing we are going to check concordant sign in extension. And also we'll see the effect of repeated or sustained movements and what is the effect on the patient's concordant sign, whether the pain centralizes or peripheralizes. This also has to go through the 7 steps. So in the first step, patient starts from the neutral standing position. Hands will be on the pelvis. Take the baseline pain and symptoms. Then in the step 2, patient will be instructed to extend backward to his or her first point of pain. Then again check the pain and symptoms. That means we are looking for concordant sign, at what point pain comes. Then in the step 3, patient is instructed to progress past the first point of pain. Where pain came, go beyond that. And again check the pain and symptoms. Similarly, step 4. Patient went beyond the point of pain. At this point, she has to perform repeated movements, either crossing the point of pain, going up to the end range and coming back. And by doing this repeated movement, see whether the patient's condition is worsening, improving or staying the same. That means whether it is centralizing, peripheralizing or none of them. So steps are going same like what we did in the flexion. Now we come to the 5th step. So after repeated movement, you check again whether the range of motion has increased or decreased. And in the 6th step, if end range repeated movement extension was pain free, then you have to take up the slack. Means therapist, you see the second picture, keep one hand over the pelvis and other hand over the shoulder and apply firm pressure to engage the end field. Means at this point, therapist will assist the patient to engage the lumbar spine in full extension. So if this position is pain free, then give oscillation. If it is painful, then don't give oscillation. So by doing this, again you can find out whether giving flexion or giving extension, which one was useful in centralizing the patient's pain and patient symptoms. Got it? Now we'll go to the third movement, that is active side flexion with repeated motion. Similar to flexion and extension, we can also use side flexion with repeated motions. Because of disc prolapse, there may be reduction in side bending or there will be asymmetry in the side bending range of motion. And this is a good predictor of disability and severity of low back pain symptoms. So the reduction in range of motion, it may be because of posterolateral disc herniation on one side versus the other side. It could be nerve root irritation with traction. It may be because of discogenic or disc degenerative height changes. So that may affect the side flexion movement. So you see the first picture. This will also go through the 7 steps plus one additional step will be there. That is, I will talk. So in the first step, patient will be starting from the neutral standing position. Hands are placed on the side. So here patient is side bending on the left. So first you have taken baseline measurement of pain and radicular symptoms. In the step 2, patient is instructed to bend to the right side to his or her first point of pain, and patient will be requested to give pain and symptoms. In the step 3, patient will be instructed to progress past the first point of pain. So in the step 2, you are going up to the first point of pain, and in the step 3, you are going past the first point of pain. Then in the step 4, you are performing repeated movements on one side, and again you are checking the centralizing or peripheralizing of symptoms. In the step 5, you come back to neutral and again check whether the side flexion range has increased or decreased during this repeated movement. Then in the 6th step, if repeated movement was on the side flexion was pain-free, therapist will take up the slack and give overpressure through the shoulder and keeping one hand over the pelvis, like in the picture on the left side. Picture 11.11, side flexion with overpressure. So after taking up the slack, you have to apply firm pressure, and in the end fill position, apply oscillation if it is pain-free. If it is painful, don't apply oscillation. And 8th point is repeat the entire sequence of step 1 to step 7 on the other side. So we saw flexion, extension and side flexion. How to check the movements. Next step is active rotation but no repeated motions. This goes through the 6 steps. You know that lumbar spine has very less rotation. So to fix the pelvis, patient straddles on the couch. This will fix the pelvis and we can see the minimal rotation which is available in the lumbar spine. So in the upper lumbar, range of motion is 3 degree, and between L5 and S1 it is only half degree. So in the step 1, we take the measurement of pain. Patient will be instructed to cross her hands across the chest, sitting straddle on the treatment table, that will stabilize the pelvis. In the step 2, instruction and emphasis on proper posture will be ensured. The lumbar spine is isolated. So this positioning of the patient isolates the lumbar spine. Then in the 3rd step, patient is instructed to rotate as far as possible to the left side. First we will rotate to the left, then we will ask about the pain. If it is painful, it is imperative to determine if the pain is concordant. So if pain is coming, it is concordant sign. In the step 4, if it is pain-free, gently take up the slack. Therapist will take up the slack and apply firm pressure to engage the end fill of rotation. So here you mind it, we are not giving repeated motion. Step 5, at the end fill position, if it is pain-free, apply small repeated oscillations. Like we did repeated motion in the first 3, here only repeated oscillation, repeated movements we are not doing, because that much range itself is not available. If pain is engaged because of this movement, don't give overpressure. Then repeat all the sequence first to 5 on the other side. First you did it on the one side, then you are going to check on the other side. So this active rotation, it will tell you the culprit is there in the facet joints, not in the disc, because this rotation movement stresses the facet joints mainly. Now we'll talk about combined active physiological movements. So when we combine the motion, means it is coupled motion. So motion is taking place in a number of planes, and it can implicate a specific structure, and we call this combined movement or quadrant movement. And this can tell you where is the origin of pain in the lumbar spine. Is it the disc or is it the facet? These motions are quite provocative or sensitive. Right? So you see this picture, what this lady is doing. She is performing combined flexion, side flexion and rotation. Means if you touch the ankle on one side, you are performing flexion, side flexion and rotation together. So this is quadrant position in flexion. So you will start from the neutral standing position, then reach downward with both hands towards the left ankle. So in the step 2, you find out whether pain production or symptom production is happening. In the step 3, patient will be instructed to reach down with both hands towards the right ankle. And again patient is queried about the reproduction of symptoms. Then in the step 4, patient is instructed to extend, rotate and side flex towards the left side, and again symptoms will be assessed. So first we check it in the flexion, then second, fourth and fifth we check in the extension, side flexion and rotation. So putting the patient in quadrant position, you can implicate the facet joints. So you see that active range of motion is necessary to find out the concordant sign of the patient. And repeated motion will dictate whether the patient is a centralizer or a peripheralizer, and whether they exhibit or show directional preference. And that will contribute to predicting the likelihood of a positive long-term outcome. So whichever motion patient prefers, that can be used therapeutically. If you are checking the total range of motion in the lumbar spine, it does not have much therapeutic value. Only what you have to see, the asymmetry of the movements. If you are performing bilateral movements, look for the asymmetry in the movements. Okay. So far, we discussed about active movements in flexion, extension, side flexion, then combined active physiological movements, and also we discussed about rotation. So that gives you idea how it can be used in detecting the structure, find out the concordant signs. Now we come to the next area, that is passive movements. Now you will think that once you have checked active movements, what is the use of passive movements? Passive movements are used basically for comparison purpose. Out of fear of willingness to move, means because of fear if patient has not moved, that you can differentiate in passive movement testing. So basically, this assessment will help you to compare both active movements and passive movements. And you can differentiate decreased willingness to move when requested. You can place the patient in a couch and lift the knee like in this picture, and you can check flexion and extension in the lumbar spine and keep your fingers over the patient's lumbar spine, each finger over L1, L2, L3, L4 you can keep. So this is called piano grip. And by doing passive flexion and extension, you can see the segmental motion in the lumbar spine. So basically here you are palpating the spinous processes to look for available movements. Now we come to physiological side bending. Again, grip is same. Your fingers are over the lumbar spine. Now you side flex the lumbar spine by pulling the knee in side flexion position. And again you check segmental motion between the adjacent segments. In the next point, we will see the passive rotation. Keep the finger over the spinous process. Do subsequent spinous process and check the isolated rotation by doing single passive movement of the lumbar spine. And this you will repeat for each segment between L1, L2, L2, L3, L4, L5, like that. First do it in one direction, then repeat in the other direction. But again, this passive physiological range of motion assessment, it is not done with any instrument. It is depending upon the patient's perception, therapist's perception. So inter-therapist correlation will be poor. It depends upon individual therapist perception. Range is increased or decreased. Now we come to the next point, passive accessory motion. This idea, hold one second. Now we'll talk about passive accessory motion. This motion is used to see the level of stiffness in the individual motion segment. These are called physiological accessory motions, and in this we check central posterior anterior motion, anteroposterior motion, and arthrokinematic glide, and sometimes we also check joint compression. These are the accessory motions available in the lumbar spine. First we will check central posterior anterior. So this idea was given by the Jeffrey Douglas Maitland. So when there is midline or bilateral symptom is present, you can check central posterior anterior motion. This process involves a 3-point movement targeted to the spinous process of the patient. So under this force application, all lumbar segments translate and rotate in a 3-point fashion, although the segment that receives the direct force application moves greater than the surrounding segments. So if you see the picture, the idea become more clear. By using a PC-form grip, so here you see PC-form that will be placed on an individual spinous process and directly will give central pressure. Posterior anterior force will be applied and we check the axillary motion. And by doing this, we can find out the concordant sign during the mobilization. By doing this, you can make out which segment is at fault, which segment is guilty, which segment is producing radicular or referred symptoms, and whether repeated movements or sustained hold can help to correct the fault. Next is unilateral posterior anterior pressure. This is also a 3-point movement targeted to the facet, lamina or transverse process. So here we use two thumbs to assess the intervertebral motion. On one side, by applying two thumbs, one each over the transverse processes, we apply direct pressure. By applying direct PA pressure on unilateral side, we can find out which segment is guilty and when it is producing concordant sign, or whether it will be useful to do repeated movements or the sustained hold. So by using this technique, you can clear the joint on one side or the other side, which is the exactly the point of fault. Third one is L5S1 differentiation. If you see this picture, the L5S1 and SI joints are very close. Just lateral to the S1 spinous process, the L5S1 facet joint is there. If you press your thumb just beside the S1 spinous process, you are going to press over the L5S1 facet joints like it is shown in the first picture. And if you keep little laterally, you are going to press over the sacroiliac joint. So either you can apply pressure over the L5S1 or you can apply pressure little lateral on the sacroiliac joint. So by doing this, giving PA pressure, you are differentiating whether the L5S1 is involved or it is coming from sacroiliac joint. Next comes transverse glide. This transverse glide is combined translation and rotation assessment. So applying your thumb, push the spine in a transverse direction, and this is a sensitive test. It can provoke pain much more than the UPA or CPA. So by giving rotational force, you can find out the guilty segments. So this passive accessory assessment is very useful to detect the lumbar pathology, which segment is exactly involved, which facet is involved, that you can isolate. Also, you can isolate the SI joint. It is just not checking the stiffness, also you are checking the guilty segments. And by doing this, you are doing the pain provocation. You are doing segmental examination. Now we have special clinical tests. Palpation is commonly used by the therapist. You can palpate the muscles, you can palpate the bony prominences, and by palpation you can see the temperature, and you can get a rough idea that where may be the dysfunction. Then there is role of manual muscle testing. Generally the larger muscles, they are not much affected in case of chronic low back pain. The two muscles which are commonly affected in case of chronic low back pain is transversus abdominis. It loses its power or endurance. Another one which gets atrophied in low back pain, that is multifidus. So changes in the muscle function of these two, transversus abdominis and multifidus, is very important. So we test them with the help of pressure biofeedback. One machine is there which is called PBU, pressure biofeedback unit. It is trade name is stabilizer. That is used to test the endurance of multifidi and endurance of transversus abdominis. And there are some special tests which can determine the discogenic pathologies. So one such test is slump test, or we simply call it the slump sit test. This can find out whether there is tension on the nerve root or there is adhesion after disc pathology. So this SS or slump sit test indicates disc herniation or chronic nerve root adhesion. This will also help you to differentiate with hamstring tightness. So you can differentiate between hamstring tightness or is it because of neurogenic origin, that is chronic nerve root adhesion. So let us repeat this. So patient will be sitting on the table with the legs hanging, and patient will be assuming the slump position, sacrum straight and upper back flexed. Then patient will be asked to extend the knee with dorsiflexion of the ankle. Then again you will load the shoulder by the therapist, means compression will be provided, and again with dorsiflexion you extend the knee, and also you can include neck flexion to sensitize the test. If there is presence of nerve root adhesion, then there will be severe stretch will be felt in the sciatic nerve distribution. Then if you release the neck flexion, then it will be eased, and if you release the dorsiflexion of ankle, further it will be eased. It will be normalized. So you can reassess by releasing the neck flexion, by releasing the ankle dorsiflexion. Then all of us are familiar with straight leg raise, very commonly used. It can also find out the concordant sign, involvement of the sciatic root because of disc prolapse. In the Maggie book, it is very nicely given. It is a passive test. Passively, it will be raised by the therapist with dorsiflexion of the ankle. If pain comes in first 30 degree, it may be acute disc prolapse. 30 to 60, it may be because of nerve root adhesions. After that, 70 to 80 degree, then it is Hem's tightness. And 80 to 90, it could be SI pathology. And beyond that, it could be lumbar pathology. To sensitize this test, you can add neck flexion and also dorsiflexion of the ankle. If case is acute, we don't go for that kind of test like the previous lumbar sensitizing. We do the test on the normal side, which is not affected. There is no radiation. This is called well leg raise test in case of disc prolapse, which is acute, or patient is having some serious pathology. Next, you can go for femoral nerve tension test. So, you will flex the knee and check whether it is stretching the femoral nerve in prone position. If not, then you engage the hip joint and extend the hip. And you can also add plantar flexion of the ankle. This will definitely involve femoral stretch. Manual palpation, it can help you to find out the instability. If motion is greater than that found with a person with hypermobility. So that you can find out with manual palpation. Here, similar to Matlin's concept, you can check intervertebral motion testing. Like you are giving posterior anterior pressure during the passive X-ray examination. In the same way, you can check intervertebral motion. And this will tell you which segment is involved. Same thing you can do in sight line. And you can measure the translation from posterior to anterior direction with a piano grip. Additionally, you can check the torsion first in one direction, then repeat it with the other side to check the facet instability. And in the prone lying, if you apply PA pressure when legs are on the ground, you can find the concordant sign. When the patient lifts the legs off the ground, then pain disappears. So this indicates that this patient will benefit from the stabilization exercises. If you strengthen the back extensors as well as hip extensors, this patient will benefit because she is having instability, which can be compensated by strengthening of the lumbar muscles as well as hip extensors. So you see, we have seen so many tests, then different types of motions. So if you use them in a combined manner, you can find out where is the exact point of fault or guilty segment, and accordingly you can choose your treatment. Right? So here we come to the end of the assessment. So you see, you don't need any big thing for assessing the lumbar spine. It is just simple movements, active movements, passive movement, accessory movements, and segmental motion test. You see, if you are a manual therapist, your hands are your instruments and your thinking brain. you can find out where is exactly pain, where is the exactly fault, and then you direct your treatment technique according to your finding of assessment, right? So if you have any queries, you can write in the chat box. Okay, so here we come to the end. I hope you have liked my presentation. Thank you. Hello, are you there? Dr. Santanu?
Yes, thank you, sir. I'm
Yes,
outside.
welcome.
Yes, sir. So you can see some question.
Yes, sir, please.
Okay. So thank you, sir, for your nice presentation. And now I go directly to the question and answer session.
Yeah,
So I would like to audience that you may ask any type of
please write
question.
in the chat box.
Yes, sir. Already someone giving you thank you and thanks for the very informative session. Okay.
My sound was audible, clear?
Yes, sir. You are good. Yes, audible now, sir. So I think it's a very nice presentation and long time. I think we have completed. It's close to 1 hour. So Shukanto Roy, he said, okay, active physiological movement is very informative information for him, sir. So,
Your sound is not audible. Please write in the chat box.
okay, sir, can you audible me, sir?
No, it is overlapping.
Overlapping is echo is there, sir.
Not echo. It is getting blurred.
Okay.
My sound is audible, clear,
Yes, sir. Sound is
but
audible, sir.
please write
I
in the
haven't,
chat box. I will
yes, sir.
answer.
Yes, sir. I haven't seen any question yet. So
Yeah.
I'm looking. No, sir. No more questions, sir. Another information for the participant that is, we are not providing feedback link now. We'll provide the feedback link after, that is at Bangladesh time after 10 p.m. because still we need time to adjust SARS logo on the certificate. That's why we have to take few more hours to complete that e-certificate. So don't worry, we will share that e-certificate on our Facebook page and WhatsApp group, and where we share that this link. So don't worry. So from there you can instantly access your certificate. So I'd like to ask the participant, do you have any question? Then I would deliver to you, sir, for the valuable answer. Okay, so I think no more questions, sir. I think they can
Okay. No
understand.
issue. Always you can share my number if they have any query. They can WhatsApp me.
Okay, so we can share your number. Okay. So you can give that number on private chat. Sir, question is now coming. So, okay, so Arif asked one question. Arif Hassan, he's asked, how can I diagnose pathological back pain? Is there any specific test?
That only we discussed. See, in mechanical pain, if you perform quadrant motion, so automatically it will implicate the facet joints. When you overload the facet joint, it indicates mechanical back pain. So for that, quadrant test is there. Quadrant test in flexion, when you're touching one side of the ankle, it is quadrant test in flexion. And when you are doing extension, side flexion and rotation, that is quadrant test in extension. So both of these are indicating mechanical dysfunction in the facet joints. And if it is disc problem, that will be producing pain because of repeated movements. You can find out at particular point pain is coming, then you are performing repeated movements, then you are going beyond the range of motion of pain, again coming back, that is centralizing or peripheralizing, and again you are repeating, going to the end point, end fill, then again you are giving oscillation. This way you have to determine that giving repeated movements is going to help or it is not going to help in one direction. If it is not helping in one direction, try on the other direction. First try with flexion, then extension, side flexion. Nothing helps, try rotation. Like that. Trial and error, we can find out, we can assess which preferential direction will help. That was the concept of McKenzie. Right, Dr. Santanu?
Yes, sir. No more question now, sir. So we can stop now, sir. So and
Yeah.
any other session we can continue.
Okay.
And another thing is, sir, you have conducted a lot of workshop on your area, like in Surat or all over the India. So
Yeah.
you can share our information. Share your
Yes.
information.
I'll come to Bangladesh, Dhaka, some or
Yes,
other
sir.
time.
Of course. After this lockdown, we can
Then I'll
arrange
show
a lot
after
of.
lockdown is over, let the corona condition improve.
Yes, sir. Of
I
course,
have
sir.
planned for Dhaka.
Yes, that's the start of that is the start of our journey. So we have a good connection in near future because it's a advertisement. I think type of work that is 1 hour is not enough. You have conducted 4 days, 8 days workshop. I think so, but there is the only we have taken the
Or
cheap of water from there. So I think that will be a great pleasure for us if we can arrange such type of practical things. Not in
yes,
Bangladesh, but we can
because
arrange all over the country.
education is
All over
purely
the,
practical.
yes, sir. Yes, sir. So manual therapy
It
is
can't be taught online.
yes, sir. So we can arrange a lot of workshops. So uh, okay, sir. No more question. I think we can stop for this time now. So
Okay. Thanks.
okay.
Thanks
Thank
for
you, sir.
inviting me. It
Thank
was
you,
a
sir.
pleasure speaking before very great audience,
Thank you, sir.
and see
Yes,
you
sir.
soon in your
Yes,
country.
sir. Yes, sir. Always we have more than. Thank you, sir. Thank you, sir.
Okay. Thanks.
Namaste, sir. তো সবাইকে ধন্যবাদ আপনারা মনোযোগ দিয়ে শুনেছেন আসলে অনেকক্ষণ একটা ক্লাস হয়েছে এবং খুবই ইম্পর্টেন্ট একটা টপিক ছিল লাম্বার স্পাইন এরিয়া অ্যাসেসমেন্ট বিশেষ করে ম্যানুয়াল থেরাপি যারা প্র্যাকটিস করে থাকেন তো আমরা অন্য কোনো সময় আরো ডিটেলস নিয়ে বা প্র্যাকটিক্যাল নিয়ে আসবো সেই পর্যন্ত সবাই ভালো থাকবেন সুস্থ থাকবেন আর আমাদের পিজিও নিউজের সাথেই থাকবেন তো ধন্যবাদ আমাদের চিফ এডিটর ডক্টর শামীম হাসান মারুফ স্যারকে এবং পাশাপাশি যারা মনোনীত আমাকে শুনলেন। ধন্যবাদ সবাইকে।